Good afternoon, everybody. Welcome to the Outcome Measures in Practice Echo for this afternoon. We're just coming up to 3:30 and we've had a quick flurry of people joining us in the last few minutes, so hopefully you're all on okay. Yeah. So my name's Kate Fleming. I'm the Head of Research and Clinical Innovation over here at Hospice UK, fairly new in post, and for those of you who are on the last Echo, I was sitting in on that and watched Max very ably facilitate you all, so welcome this afternoon. It's now 3:30, so we'll officially start. Can we just get everybody to put their names in the chat box, just to check that we've got absolutely everybody and we don't miss everybody. Hazel's here with me in the room, and she'll be muting and unmuting you and seeing us safely through the afternoon. So what would be great if we could go around and introduce each other's first, and then we'll do a very brief recap on the last Echo, and then I'll introduce you to Ray, Tracy and Denise, who are at South Eastern Healthcare Trust, who are going to do the first plenary this afternoon. So Jane Newsom, may we start with you?
Is Ian stuff on? Is he going to be a coroner?
Oh, yep. Hello.
Hi. Hi, Jane.
Hi. Hi. So, yeah, I'm Jane. I'm a volunteer at Hope at Trinity, and Janet's joining us today as well. And Janet's from Hope at Trinity as well, but we're both accessing it from different places.
Lovely. Welcome this afternoon. Thank you. And Christine Jeffrey.
Hello.
Hi, Christine.
Christine Jeffrey from Ready Grove, and I'm the Quality and Audit Facilitator, and with me is Heather Ballard, who is the Clinical Audit Lead. Hello.
Hello and welcome. Then we've got Fliss Murtaugh online as well.
Hello, I think I know a lot of people, and I'll be talking a bit later on. I'm based in Yorkshire, but I'm currently phoning in from Kent.
Thank you very much, Fliss. Welcome this afternoon. And then we've got Ray, Tracy and Denise.
Hi, Ray Elder, South Eastern Trust. We'll be talking later on.
I'm Tracy Anderson, Fellow of Medicine in the South Eastern Trust.
Denise Cranston, Clinical Facilitator within the South Eastern Trust.
Thank you very much, and thank you for joining us this afternoon. We're looking forward to your session. Lisa and Amy at Butterwick. Hi.
Hello. Well, Lisa and Amy, we're from the Butterwick Hospice. I'm one of the sisters and Amy's our clinical secretary. Nice to meet you all.
Nice to meet you too, welcome. Victoria Bradley, can we go to you next?
Hi, I'm Victoria. I'm one of the consultants working in Oxford at Sobar House Hospice.
Hi, welcome. And Kimberly Rice.
Hi everyone. Oh, I need to demute.
No, we've done that for you, don't worry.
You've done that for me. Oh, it's so efficient at this. Hi, I'm Kimberly Rice, team lead for the rehab team at St Helena in Colchester. My friend's abandoned me today. She's normally sat by my side, but Jane is also a colleague of mine, so it's nice to see another familiar face.
Oh, lovely. Well, you're very welcome this afternoon. Laura Bass at Marie Curie. Hi.
Hi, I'm a specialty doctor at Marie Curie in Bradford.
Okay, welcome this afternoon. Alison Landon.
Hi, I'm Alison Landon, one of the doctors at St Christopher's in Sydenham.
Okay, thank you very much. Well, welcome. Grant Usmar. Hi.
Oh, Grant, could you unmute yourself, please?
Just having a little bit of difficulty hearing you at the minute, Grant.
Okay.
That's the one. Yes, thank you very much.
Sorry. I'm from Hospice of the Valleys in Gwent in Wales. I'm the chief exec.
Welcome. And up to Wigan and Lee, there's a collection of you there. Hello.
Hello.
Oh. Hello. We get away from Wigan and Lee.
Clinical Director, IT Manager, Community Services Manager, Inpatient Unit Manager and Quality and Governance Lead.
Thank you.
Thank you.
Hi. Okay, and then we've got people at Hull York Medical School, Andy Bradshaw.
Yeah, so we're from Hull York Medical School, part of the Resolve team, and so I'm the research fellow on the Resolve team, Andy Bradshaw, and
I'm Asim Khamis. I'm the data analyst on the Resolve project.
Well, welcome this afternoon. And we've got Janet.
Hi.
You're on your iPad. That's all I know.
Yes, well, I work with Jane at.
Okay, we've linked you up.
Centre manager.
Lovely. Thank you very much. Okay. Welcome. Lynn Partington.
Hi there, I'm Lynn. I'm Evaluation, Quality and Performance Team Leader at the End of Life Partnership in Cheshire.
Lovely, thank you very much. And finally, Patrick Fitzgerald. Are you okay? Hi, Patrick Fitzgerald. Can you hear us?
Would you like to mute yourself? I don't think we can hear. We've got Isle of Man with us as well. Is that Ben?
We've got Ben from the Isle of Man.
Ben, could you unmute yourself, please? Sorry, I think you've muted yourself.
Oh, okay, sorry. Yeah. Ben, Hospice Isle of Man, can you hear us?
You're still muted, sorry.
You can hear us, but we can't hear you at the minute.
There you go.
Lovely. Well.
Okay, yeah, so I'm Ben Harris. I'm a colleague, Professor Sarah McGee's with me too, but she just stepped outside. So.
Okay, that's fine, no problem at all. Welcome this afternoon. And Patrick Fitzgerald, can you hear us? Hi.
Yes, I can. Hello. I'm Patrick, a medical director at Woolerwood Hospice in Ashton in Greater Manchester. I'm just about to be joined by Nikki Byrne, who's our day services lead. Nikki's here. There we are. We're plagued with ill health around us, so that's why we're sort of in and out of the room because there's no one else doing the work.
Okay, fair enough. Well, understand if you go then, don't worry.
But bear with us. Apologies for being in and out.
No problem at all. Hi, then we've got Georgina Parker. Hi, Georgina Parker, can you hear us?
Could you unmute yourselves, please?
There we go.
Oh, there you go.
Brilliant.
Hello.
Hi.
My name's Georgina. I'm one of the consultants at Heart of Kent Hospice. Hi. And I'm Kerry Harrison. I'm Patient Services Director here at Heart of Kent.
And I'm Christina. I'm Head of Information at the Heart of Kent Hospice.
Fantastic. Thank you very much. I think we've got everybody now and everybody can hear us.
I've just also got Sarah Wells.
Sarah Wells. Apologies. Hi, Sarah. Can you hear us?
I can. Sorry, I'm just trying to get my video working, but yes, I can hear you.
That's fine. We're very welcome and we'll see you later, hopefully. So this afternoon, we're kind of building on from the last session where we looked at phase of illness. And I think what we're looking at this afternoon, where we start to look at how outcome measures can work across settings, builds very nicely on the phase of illness work we talked about last time. So without too much more ado, if I can head over to the Southern Eastern Healthcare Trust, to Ray Elder, Dr. Tracy Anderson and Denise Cranston. They're presenting the first session this afternoon, looking at making outcome measures work across settings. So over to you, thank you.
Hello, thanks very much. Hopefully everyone can hear us okay. If you have a problem, just shout. I will have to remind myself that in Northern Ireland we do speak rather quickly, so I will have to slow down a little bit. When we were putting the presentation together, I went back to reflect on the first meeting we had that Max took us through in London, right at the very start of this process. And one of the questions I was asked by Max then, would I describe some of the thinking within Northern Ireland around strategic planning, systems approach, and how IPAWS could fit in with that. So that's the nature of the presentation at the start, and then we're going to finish off the presentation looking at a patient's case through that. So I want to move on to the next slide, please. Northern Ireland has been going a little bit of a change over the last period of time in terms of trying to reflect on the health service provision that we have. I suppose the bit that we're slightly different from our colleagues in England and Wales and in Scotland is that we have a health and social care system. It's a joined up approach. So therefore, the healthcare service in Northern Ireland is responsible for the totality of care, both within a primary care setting and within a hospital setting. About 3 years ago, Professor Bengoa was asked to do a piece of strategic planning for the region of Northern Ireland, and that work was called Systems Not Structures. And basically the 3 fundamental areas that was identified within that programme was improving the patient's experience. It was about improving population health. So what was our understanding of epidemiology? And what were the challenges that were likely to come in the next period of time? And it was also about achieving better value for service provision. So was there duplication of service across the system? In light of that piece of work, the Department of Health produced a document called Health and Wellbeing, which was the strategic direction to 2026, and was called Delivering Together. And that was about a simpler and easy access into healthcare, and that was both for patients and also professions involved in delivering that care. It was about enabling patients to be cared for within their home environment rather than being admitted into a hospital environment. Hence the last one was reducing unnecessary hospital admission. So we move on to the next slide, please. So these are some of the policy drivers specifically relating to palliative care. In 2010, we had a ministerial document called Living Matters, Dying Matters. We were the only region at that point in time that didn't have an end-of-life strategic document. England did have one, Scotland had one, Wales had one, so Northern Ireland was the last in the region to produce one. As a consequence of that, Palliative Care and Partnership Programme was established in 2016, and it is responsible for the delivery of palliative care across Northern Ireland. So it is department-led, Department of Health, the Public Health Agency, plus all the 5 healthcare trusts in Northern Ireland feed into that strategic overview. We had a number of other documents. So in 2012, with Transforming Your Care, which is about funding primary care differently. We then had Transforming Your Palliative and End-of-Life Care. We had a RQIA review in 2016. You have HQIP, if I can remember right, in England. This is our equivalent, so that's our inspection side of things. And then we had a piece of work produced by the All-Ireland Institute of Hospice and Palliative Care, working across the All-Ireland context around about the patient's views about, tell us what you think palliative care should be. So when we put all of that together, next slide please. Thank you. We ended up with a strategic plan for the next 6 years with priority areas identified as identification, key worker, advanced care planning, and palliative care service provision. So identification is, how do we understand where palliative care starts? How do we identify who those patients are? How do we do that within a GP setting, within a district nursing setting, within a hospital setting? There was some confusion around about who the key worker may be for a palliative patient. So a decision in Northern Ireland has been that the key worker within the primary care setting will be the district nursing team manager. That could be a sister or somebody else. It's also about advanced care planning, or to use the newer language that appears in NICE, it's about setting up an individual care planning, which is a live review document. And we also reflected on our palliative care services. Did we have the right makeup? Did we have the right number of doctors, right number of nurses, etc. within that? And we've just finished a strategic workforce planning review of palliation within Northern Ireland. And out of that, we've got some extra staff. That doesn't say it's staff. If you have one trust which has 10 nurses and another trust which is only 6, the question then and the challenge for us was, does that trust actually need 10 nurses, or can we share some of those nursing staff differently, so it's a different way of thinking. It's also about using good practice tools. It's about communication skills and training, and we're now embarking on the public health approach and debate around about palliative care, so it needs to be a cultural change and a cultural shift in our thinking. So we'll move on to the next slide, please. So from a South Eastern Trust viewpoint, given the strategic context and the Department of Health context for Northern Ireland, within the South Eastern Trust, part of my role and function here is to help my organisation understand the strategic direction and planning. I'm also responsible for the management of the clinical aspect of delivery of palliation across the Trust, so that's within a hospital setting, but also within the primary care setting. So part of the main drivers for us is to prevent hospital admissions. We also need to have a look at those patients who are appropriately in hospital. Can we facilitate an earlier discharge out of hospital? What does the continuity between the acute and community care currently look like? Is it about, from a consultant viewpoint, can I get consistency between the consultants I manage within the hospital setting? Can we look at their role and function within the community setting? And it's also about social work provision, for instance, just as another example. And is there a future way that we could develop this differently within our hospital setting? We'll move on to the next slide, please. This may be slightly small, but hopefully you can follow my thinking through. It's quite a complex model. So if we start at the dark blue circle, which says GP and district nurse, so if we take a patient who finds themselves within that setting, we are using the enabling system that was developed by Scott Murray and his colleagues in Edinburgh University to help GPs start to challenge some of the questions that they would have of patients that they find in their practices. So we're trying to understand comorbidity differently, and if we join comorbidity up differently, does that mean that we could perhaps have an earlier palliative conversation with district nursing? And we're using that enabling tool developed by Scott and his colleagues to help us shape that conversation. It may be that the district nurse, through visiting at home, starts to identify that something may be changing within that home around the palliative patient. And in order to facilitate that patient staying at home, we might need to add an extra social care within that. So it's to try and encapsulate a different conversation within the primary care setting. We're trying to encourage palliative meetings more regularly within GP practices. Some of our practices here have a meeting every 3 months, which we feel is slightly too long. And we're trying to say, well, how can we help and support that discussion earlier? If through those discussions the GP and the district nursing feels that a patient needs to come to the acute setting, they follow the broken blue line and they find themselves in accident and emergency departments across the 3 hospital sites. The only access at this point in time into any of our acute hospitals is through accident and emergency. Now we know for palliative patients that's not a good place to find themselves. I'm not sure what it's like in England, but certainly or Scotland or Wales or the Isle of Man. But for us, accident and emergency departments are extremely busy places, and they are not appropriate places to have end-of-life conversations or around about the identification that somebody may have a palliative care need. We are starting to do some work scoping, and we have developed a tool with ourselves and Brown University in the States to help us identify unmet palliative care need within accident and emergency departments. But we can talk about that later on if people want to see a little bit of that work. If a decision is made for somebody to be admitted into hospital systems, into our service, we have developed a new e-referral system to help us identify the needs of those palliative care patients. And then we move to the totality of the outcome assessment, complexity, collaborative. So my teams will use the integrated palliative care score tool. We'll use phase of illness, and we'll also use Konoski to help us understand the start of that palliative journey within the acute setting. What we're hoping to do then is when a patient is discharged out, that assessment tool that we've already started within the hospital setting will be part of the discharge planning process, and the GP then will have an understanding of where the patient is at when they drop back into their care within the primary care setting. We've just recently opened a new community palliative care centre, which is the Purple Centre. And again, a patient for earlier discharge may be reviewed within that centre, and that is a multi-professional centre, so it's led by Tracy. And one of the patients we'll talk about has recently used that facility. And what we're hoping to do then in January is to switch on the PAVE, and PAVE is patient assessment in a virtual environment. So we want to take the MDT meeting to the patient's home, where we will work with a professional in the patient's home, and through Zoom or other technologies we'll come into the MDT meeting. We'll be able to share scan results, blood results and so on with the patient, so we have that live discussion in the patient's home, so they don't have to travel to see us, and we can plan differently for them. So hopefully that's a quick run through of the model, and hopefully that makes sense to people. This was just to give you an idea of our electronic referral form, and then so it helps us understand then in terms of our demographics, our diagnosis, reason of referral, and our content. And it helps us with earlier decision making. It's about caseload allocations, facilitation, joint management planning, etc., and onward referral out. If we move to the next slide. Okay, this is just an example of the number of people that come through the service. So we had just over 1,252 through the hospital team last year. That number has increased to about 1,800 this year. And even though we have been trying to change our process, what we have found as we've expanded the concept of palliative care beyond the cancer arena, the number of admissions of people coming to hospital with palliative diagnosis has increased. So we still have some challenges around. About 4 years ago, length of stay within the acute hospital settings was about 13.6 days. We have that down to about 6.9, so 7 days stay. So we'll have decreased the length of stay within hospital and facilitated earlier discharge out. So how is this interpreted? Sorry, next slide. It's about designing something which is responsive to change. Within the Northern Ireland context, as I've said, we have widened the palliative care debate out beyond the cancer arena, which I think is the right thing to do. So it's about long-term conditions, it's about comorbidities, it's about frailty, but it's also about neurological conditions and rare diseases, which we're finding we're being involved with. It's about heart failure patients, and it's about helping us to maybe use our clinical decision-making processes slightly differently. Is it about the course of the disease, and if it is, what's the appropriate intervention? And we have found IPAWS and that thinking very helpful in terms of challenging ourselves in terms of, is this something that we've done historically this way? But if we think about it this way, can we do a different type of intervention to that? And it's dependent on clinical centered reasoning or rationale. So if a patient now says to us, my goal in life is to stay at home for as long as possible, historically we would have said, well, that's very well and good, but in order for us to support you or care for you differently, we're going to need you to come to see us. we're now saying, can we use our staff differently? So for instance, can we do a scan at home? Can we do something differently at home? Or can we use a facility closer to the patient's home rather than coming to a tertiary centre to be reviewed? Next slide, please.
Ray,
So
can I just interrupt there? I've got a question from Fliss about unplanned admissions. Fliss, do you want to?
Yep.
A quick question just to say whether you had also assessed if there was an impact on the unplanned admissions. You mentioned length of stay, but I just was interested to find out if that had also made a difference.
In what sense? Ask me again.
On the previous slide, you had said that there had been a reduced length of stay, and I just find if you'd also assessed whether there was an impact on unplanned admissions.
We thought there was, but the reality was no. Certainly from the group of patients that we knew of, yes. But what happened was when we started to scope out, because we couldn't understand why our caseload was still increasing within the acute hospital setting, because we thought we were doing reasonably well with the patients we already knew, and we had a different plan for those patients within the community. However, what we found was as you change the system in one area, so GPs are starting to ask different questions of the patient groups that they're seeing through their clinics. And those patients then were finding themselves in the accident and emergency departments, and my teams may not have known about them at all because they were new people coming in.
Yeah.
And what we found with the accident and emergency piece of work is that we're using a screening tool to help us identify those patients earlier. And we're asking ourselves the questions, if we're identifying them within an accident emergency department, is there a way that we might be able to support that person getting out of hospital before they actually find themselves in a bed? Because if you find yourself in a bed in an acute setting, there's a whole chain that happens then. So there's a different type of assessments happen, different type of people have to come and see you, so you get caught in a system. No, that's
sounds like you're increasing your referrals anyway then by other interventions, and also everybody across the country is getting an 8 to 10% increase in referrals year on year, so it's really hard to judge, isn't it? Yeah, thank you.
Yeah, I don't know if that answers your question. Hopefully it does.
Yeah.
Right. And there's sorry, if we take another question from Jane Newson, you're talking lots about home. Jane, do you want to say a little bit more about that?
Yeah, I just wanted to say, are you sure that these people have a home?
Okay, whenever we say home, we are talking about where the person finds themselves being cared for. So that could be in home in the traditional sense, it could be a nursing home, it could be a residential home. If your question is the person homeless, for instance, or are they being cared for within a prison setting, we also have links into those organisations as well. I think one of the big cultural changes for us is about an individual choice. So if somebody says, I want to be cared for here, and we as a clinical team feel perhaps isn't the best person or best area for that person to be cared in, it's about autonomy of the individual. And as long as they have the ability to make that decision for themselves in terms of they're not cognitively impaired or they don't lack capacity, however difficult that is, sometimes we need to support that person where they find themselves. I think it was one of the charities in England did a very helpful DVD a number of years ago called Can You See Me, I think it was called. And it was about working with homelessness. I found it personally very challenging, and I think it's sometimes within that professional environment we haven't got it right, and we have a long way to go.
I guess
I'm not sure if that's what you were referring to.
I guess not so much talking about palliative care needs, but we are seeing people discharged from A&E onto the streets. And we have got someone who has got lots of comorbidities that she's living in a doorway, and it's a real challenge to get any help for her, really.
And I suppose we have a slight advantage in that because there is a continuity of the care provision. So there's a statutory function and responsibility if we discharge somebody from our hospital settings that we need to ensure as a trust that the care and support of that person is in place where possible. Now we don't always get it right, but if that scenario that you are describing, certainly we would have possibilities where that person could be discharged too. But again, it's the balance between what does that person want for themselves and what would we think would be appropriate for them. And that's one of the huge ethical debates that we're finding. The other big challenge for us is as people get older and come into our service, people will say, well, my son or daughter will care for me, but that person could be well in their 90s and the person caring for them is in their late 60s, early 70s. So it's about, as people live longer and come into our palliative care service, we're being stretched in terms of what that care might need to look like for the totality of the family rather than just for the individual patient.
Yeah, thank you very much.
Okay, so how is it reported? Well, it's about how do we inform care planning, so that's about the individual patient. It's also about, the challenge for me is if we identify something within our own service provision which we lack. So for instance, I am reliant very much on my colleagues from the hospice sector or from a charity environment to provide for me counselling support, that psychological ongoing support. So it's about how do I balance that? So do they come as part of my team? Do we work in co-production? What does that actually look like? The care environment, we do not have enough hospice specialist beds within the Northern Ireland region, which has a knock-on effect in that some of those patients that we feel would be served well within that environment, we can't get them discharged out of hospital because there is a lack of service provision, not through the hospice's fault, but just how the services have been commissioned and set up. And it's also about that interlinkage in terms of the clinical learning that we bring to the care of our patients and to their families need to be shared with senior management within my own organisation, but also at the Department of Health. And how do we influence commissioners differently? And how we do that is, if you go on to the next slide, this was something we shared at the commissioners. Now, I know it's very small on the screen, and apologies for that. We looked at some of the work that Fliss had produced in terms of how she reflected back on how do you score your assessment tools and so on. But we wanted to try and get it distilled right down into a very simple tool that we could describe it to commissioners who perhaps didn't understand our service as the intricacies that you and I would understand it as professionals that work in it. So how we have described it is that we've taken assessments and we have said a green arrow is there is an incremental improvement in the patient's care around about those pain or those areas of IPAWS. Red is there's been a deterioration, and orange is they have remained as it were. And it was quite interesting. They actually got this pretty quickly. And we're saying palliation is not about huge changes for people, it's about the small incremental changes which makes a huge difference to somebody's life. We're not sure, this is what we call OBA, outcome-based accountability on a page. And we're not sure if this is the right way to report it, but for the needs and purposes of those individuals that we were sharing IPAWS with, who had limited understanding of the complexity of it in terms of that totality of the palliation journey, it appeared to work from that viewpoint. So this was shared with the Department of Health within Northern Ireland. If you move on to the next slide. And I suppose this is just about doing it in a slightly different way. So what was problem, the top in the problem assessment 1 moved to the second stage in assessment 2. So I suppose it's just another way of actually trying to describe it on the page for someone. And then if we move on to the barriers then, which is the next slide. So it's the appropriateness with vulnerable individuals. I know you've had the Mental Health Capacity Act in England for a number of years. It's being brought into Northern Ireland under the auspices of the Mental Health Capacity Act. For us, it's a slightly different piece of legislation. So what Northern Ireland have done is have taken the learning from England and they've adapted and put it into here. So part of this is around about individuals' capacity, about an individual's liberty if they have a mental health condition. But it's about the vulnerability of those individuals who maybe have no one to care for them when they go home. And it's about when is it appropriate to do the assessment? How do we do the assessment? How do we have that conversation with someone? How are we empathetic and also at the same time need to be clinical in terms of our understanding of process and change? I know there's been lots of really helpful discussions around about phase of illness, and it's about that ability to say, well, this is why we think something is changing for you. We'd like to add something in, and it's how do we describe it, I suppose, as we've tried to do on a page to help us understand if we're trying to get it right. So this is vulnerability for us as professionals, but also for the individuals that we're actually working with. And I think the two sit within tandem. It's about the time required and the balance that as a manager of the service I need to put in place in terms of how do we administer this. Do we do it in 10 minutes? Do we do it in 15 minutes? Do we do it as an hour? What does it actually look like? As Fliss has already indicated, we all live in a world where there's an increase year on year about those patients that have a palliative care need. And therefore is IPAWS or the wider IPAWS school of thinking, is that the best and the most appropriate way? And is it value for money? Is it value for staff time, etc.? And is it investment? So time, process, how do we interpret it? How do we actually report it? What does it look like from an IT viewpoint? And I've alluded to some of the areas that we've tried to report it in a different environment outside the clinical to help us drive our service change forward. And I think, Fliss, you mentioned this in one of the very early meetings. It's about how do we embed the education in. We have tried to use this as a totality model for the whole trust. So that implies not only education within our acute settings, but within our primary care teams. So that's about district nursing, it's about social care, it's about GPs, it's about IPAWS thinking within different disease groups. And that's very time consuming. We think it's the right thing to do, but we're struggling to actually look at the best way to educate that. Is it through ECHO? Is it through consultant to consultant? Is it consultant group? What actually is it and what does it actually look like? And I think we have to be realistic. We have to be scrutinised to say, actually, is this the right way to do it? And part of our reflection, which Tracy is now going to share, is about our thinking in the whole systems approach for a patient. And if we use IPAWS as a thinking model or a way of working with a patient from acute into primary care, back into acute, into GP, does that model of thinking and support benefit the patient through the whole journey and through the whole process? Hopefully that bit has made sense. Are there any other questions before we go on to maybe quickly have a look at the clinical aspect?
Has anybody got questions? Okay, thank you, Ray. That was really helpful, enlightening look across the system. And now it'd be really helpful to hear the case from Tracy. I'm a little bit conscious of time moving on, but hopefully we've got enough time to hear about the case as well before we have a little bit of discussion and then move on to Fliss's work as well. Thanks, Tracy.
Okay. Well, what I really want to do is just largely highlight one case that then Denise will follow up with, just showing us how we've brought the IPOS assessments into that. And I'm hoping the patient journey that I will describe to you will just put that in context. But even just before I do that, as I'm reflecting on some of the comments that are being made as we talk through this so far, and Ray's also has given you a background of where we're going strategically in Northern Ireland. But what we're doing as a trust is trying our best to reach out into the community and to try and look at how many patients we can see in a community setting to try and prevent those hospital admissions. But as we reflect on the number of admissions that come to our hospital team and look at why those patients have been admitted to hospital, interestingly, and I'm sure a lot of you will find the same, probably about 80% of those patients have come into hospital with either a new diagnosis or an acute issue that couldn't have been managed at home. So I suppose the cohort of patients that we're really trying to target are those 20% who are coming into hospital with either an expected deterioration in their condition or with symptoms that we could have predicted, and can we capture them in the community, deal with those things, organise those investigations and try to prevent them coming into hospital. So those are the kind of patients that we're trying to target. I'm fortunate in that my role is across settings, so I work partly in the acute hospital but also in the community, and that is in the community palliative care centre that we've just recently opened, but also that's reaching out into the community and going to patients' homes when they aren't well enough to come to the centre. And before I go to the case that's highlighted here, I just want to pick up on the point that somebody had made about do all patients have a home to go to, and we're probably more sheltered in Northern Ireland than maybe many of you would be in other cities in the UK. However, on our current centre caseload at the minute, there is one man who does live in a homeless hostel. So I have been able to look after him both in the community setting, coming to see us in the centre, and also when he has had his acute hospital admissions because of an acute infection. And we've worked together as a team in that situation to get him discharged back out to his hostel, with a lot of anxiety with the hospital staff about how well they'll be able to manage him there. But we've been able to send our AHP staff out to have input. We've been able to send our social worker out to have input with the wider complexities of the social situation. And so far we've managed to keep him in the hostel environment, despite it not being an ideal place for him. But there really isn't another alternative place at this point in his journey of his illness. So we're working together with that sector to try and keep him there, because that is his home. So anyway, moving on from that, I just want to highlight a case of a patient that I've looked after recently across care settings, that we have used our IPOS tool as the prompt to let us to highlight to us that she needs a further review, and then Denise will follow it up with a wee bit more detail about the IPOS. So this lady is a 76-year-old lady. She's quite a recent diagnosis of a pancreatic cancer, and she was metastatic at diagnosis with both liver and lung mets. She was admitted to hospital and was diagnosed in hospital, and she was referred to the hospital palliative care team for symptom control during her hospital admission. So the acute phase of her treatment had been completed, but she had ongoing symptoms. So we were able to discharge her from hospital with a prompt follow-up 5 days later in our community palliative care centre. And at that time she had ongoing symptoms, but we were able to alter medications, repeat her bloods and organise an ultrasound scan as an outpatient. So she was followed up a week later as a telephone review with a plan of discharging from her caseload if her symptoms had been settled, but her symptoms were actually ongoing. The ultrasound was due to be a week later, so we planned a follow-up review in the centre 2 days after the ultrasound scan. Do you want to move on to the next slide? Now, unfortunately, trying to plan these investigations as an outpatient, she was one of those 80% of patients who actually ended up coming into hospital, but the reason for her coming in was an acute issue. Her LFTs had worsened, she became generally unwell, and she had a valid reason for coming into hospital, because when she was investigated in the hospital, her stent was blocked due to tumour progression. So she did have her stent replaced. She was an inpatient in the hospital for 11 days. She was seen a number of times by the specialist palliative care team in hospital, and a syringe driver was started for symptom control, but her symptoms were still ongoing. But because we were able to follow her up soon after discharge, she was discharged home from hospital, but her phase of illness was still unstable at that time. So she was followed up by oncology 2 days after discharge, and then 5 days later came back to see us at the Community Palliative Care Centre, at which point her symptoms were worsening. She was now opiate toxic, but her pain was still a problem, and her overall condition had deteriorated. So we were able to check her bloods and realise that her LFTs were also worsening despite the new stent. Do you want to move on slide again? And because her symptoms were not resolved, her condition was still unstable, we were able to then organise an urgent admission to our local hospice. And through that, I think through being able to review her promptly, organise some investigations as an outpatient, we hope we were able to avoid a hospital admission on that occasion, because I think because of her declining condition, she probably would have come through A&E if we hadn't been able to see her quickly and organise an alternative. So I'm going to hand over to Denise to highlight how we used IPOS within this case example.
So just going on the patient journey, and obviously you've got all the background there. I then went and pulled the IPOS scores for this particular patient. And although you can see there from the slide that so back to what Ray said, patients come in, they're referred, they come in on the electronic referral, and then the team will go out and do the assessment. So we did that initial IPOS assessment. We used the 3-day recall with our patients, and then we have a conversation. Because of the vulnerability of our group of patients, we don't necessarily ask the patient to fill the IPOS in themselves. This is a joint conversation between the nurse and the patient, and the IPOS is scored. So on that initial one, the patient was unstable. They had an AKPS of 50%. And the main problems reported at that time was pain and the vomiting and anxiety. So we have we're trying to work our way through this. It's new to us, so we're trying to work our way through about when we do the second IPOS, and we know that it's supposed to be at phase change. But this patient, the phase was still unstable. So on discharge, her IPOS was that she was still unstable. She was medically fit from her admitting consultant's point of view to go home from hospital, but her with regards to palliative care, she was still unstable, but her AKPS had increased to 60%. Her main problems at that point in time, there were still pain, there was nausea and the anxiety, but it's important to say that the actual individual scoring of those items, the pain had gone from severe to moderate, and vomiting had gone from being vomiting to a nausea. So there had been changes within those individual scores. Although she was still unstable, there was still things needed to be changed within that care plan. Because now we have the community centre, the patient was coming up to the centre, and we decided that they would complete an IPOS there as well. So within the centre, and this was on the last IPOS just prior to the patient being admitted to the hospice setting. She was unstable during that IPOS assessment. Her AKPS had deteriorated. She had gone down to 50%. Still pain, albeit that the pain was still moderate. But the main problem at this point in time was the opioid toxicity, and that was the reason why was needing the admission into the hospice to have a look at those medications, to look at the care plan, to look at the changes that needed to be done for that individual. So that was just taking IPOS and kind of doing that mapping across to your patient journey. Do you want to go on to the next slide? So what we're looking at now is that with regards to obviously trying to join the IPAWS together with everything else that we're doing within our service, we're looking to see about revising our coding system, and we're going to look at in line with the national benchmarking and national returns to try and make sure that we're able to map those things across. Because those patients can come back into hospital and they're appropriate to come back into hospital, we're looking to try and develop some kind of a symbol or something to identify that those patients had palliative care input on a previous admission, so that then it's flagged, that those patients are flagged to our service at an earlier stage. So we're looking to see about trying to identify those patients within our own internal systems, and also looking to see about including those outcome-based measurements along with within our specialist palliative care team. So at the minute we only use IPAWS within the specialist palliative care service. It's not used within any of the other services within the hospital because they're still learning for us, but it's something that we would like to maybe develop into some of the other teams within the hospital. But at the minute we are only using it within specialist palliative care, but we are aware that there are renal IPAWS and other IPAWS out there that could be adopted and used within the service. So that's kind of where we're at with our IPAWS, and that's the end of the presentation for today.
Well, thank you very much indeed. That was hugely helpful for all of us, I'm sure, and again builds on the phase of illness work we were doing last time. And it's been really interesting, I think, to look at the system as a whole and look at the patient journey within that system, and then within that to see where IPAWS can map onto it. And I think what really struck me was actually how kind of the Oak Suite of measures can start not only improve patient experience, but start to provide leverage within the system as well when you're starting to feed it back. So I think it's kind of really beneficial to see how well it can be used across the settings, and great to see how a new centre, the Community Palliative Care Centre, is impacting on that system as well, and the patient journey, and also then where you can use IPAWS. So thank you very much. So I'll open it up to questions for everybody now. So we've got about 10 minutes for questions before we move to Fliss. Is there anybody who would like to start?
I've had a question from Fliss. Would you like to unmute yourself and ask?
Welcome, Fliss.
I've always got a question, so
that's great.
I guess I wanted to ask about the case, whether you thought the use of IPAWS actually changed anything?
I think asking the question about whether the patient is stable or unstable at the end of our intervention in each care setting was a helpful prompt as to whether we need to review promptly again, because we're trying to really make sure that we use particularly our community palliative care centre, that we keep it very quickly responsive to see patients quickly who need to be seen, but not seeing patients who are stable that can be looked after by other people. So it's been really helpful to help us work out who we need to quickly follow up, and then when we did follow her up, or when we did do the telephone review, then we realised there were issues that we then needed to follow up on again. And I think if we hadn't been involved in the community, I think inevitably we wouldn't have had a quick follow up and maybe would have ended up back in hospital. So to be honest, just asking the question about stability has been really helpful.
I suppose I would answer it slightly differently. I was asked by the Health Minister a number of years ago, how do we standardise our practice within a complex area? Or his question, not standardise, that's my words. His question was, are all palliative care patients cared for the same, looked at the same way? I interpret that as, how do we start to understand complexity in palliation to try and use a standard way of doing it for every patient? So I've come out from a slightly different viewpoint. So all patients that come through the hospital service within my teams, within specialist palliative care, the mechanism that we're using to try to standardise our practice is to use IPAWS as our starting point for that patient.
Okay, thank you very much. I've got a question from Heather Ballard, please.
Hello, it's Heather here from Rennie Grove Hospice Care. I just started on the project and I'm interested, well, certainly I wanted to echo Ray's areas about the investment of time, the time to educate and the goalpost shifting within organisations. The community goalposts are often shifting and we have a lot of changeover of staff and changeover of education teams, so I'm definitely echoing that from our point of view. One of the things I was interested in for a question for Ray, right at the beginning in the systems approach, you were talking about the number of nurses and you didn't expressly say whether you use a dependency score or are you using IPOS to support dependency scoring at all?
Sorry, you dropped out at the start of the question. I didn't catch the first bit of it.
Sorry, I was interested in the systems approach that you spoke about at the beginning in terms of the number of nurses you need. And I just wondered if you'd used IPOS in a dependency scoring way at all.
I suppose it comes back to that piece of work was actually undertaken by the Department of Health, and they asked the question of Northern Ireland region, do we have enough individuals working within the palliative care arena right across from primary care into secondary care? What we were able to do was, when we discussed the nursing cohort, we were able to use the fact that we were moving towards a standardisation of how we were asking the questions to help us argue why we needed more specialist nurses within this area of practice. I think the other challenge for us was if we increase the use of IPOS, I will become more dependent on the time that my nurses need to spend delivering IPOS. So therefore, I will need to increase the number of nurses that I actually use. So I suppose it's a double-edged sword. And I think they did listen to that rationale from a regional viewpoint. But the other challenge that they had for us was, because it is one funding pot in Northern Ireland, their question was, as a manager of the service here, have I got too many nurses and have I got too many doctors? And if I have, am I willing to give some of mine up? And that's a very difficult question to answer.
Silly question. Thank you.
Is that okay? Fliss, did you want to come in on that?
Yes, I think it depends how you use IPOS and when you use IPOS as to how much impact it has on time. I would say that phase and AKPS have very little impact on a staff time because they are both things that I think are readily assessed if you've done an assessment. I think the same is true of IPOS to some extent, but it does take a little bit longer, and I think on average we're finding that it's about 2 to 5 minutes per IPOS when somebody's familiar with IPOS. So you just need to think about factoring that in. What's more difficult, I think, is the initial training.
Yeah, we would say about 10 minutes for the staff. Now, you're quite right, Fliss, once you get used to it, asking the questions. I suppose what has been really helpful for us is that it's challenged us to think differently about our MDT meetings. If we're using IPOS as that standardisation for every patient, as Tracy has already said, it's about that question about stable, unstable. And we were not challenged recently, but I had a colleague with the medical director recently, a discussion about a hospital may say that somebody's medically fit to leave, but from my service we're saying they're still unstable, and they were trying to get their head around that language and that actual thought process. So how I described it was that the rationale for why the person came into hospital, it may not have had anything to do with palliation. It may have been to do with a broken leg, for instance. So therefore, how we look at the totality of palliative care and how we assess it is different from somebody who's assessing somebody with a broken leg. I probably haven't described it very well.
I would always, always use the phrase palliative phase of illness.
Yeah.
Palliative phase deteriorating, palliative phase unstable. because there are other disciplines other specialties which use phase in different ways.
Okay.
And there's also the issue of the deteriorating patient in the acute care context. And I think if we don't use that qualifier when we communicate outside of the palliative world, we will run the risk of really confusing people.
That's very helpful, thank you.
Yeah, thanks. It's really helpful to get that clarification, I think, across the terminology. Thank you.
Yeah.
Is there anyone else who's got a question either around their use of IPOS or across different settings? Grant. Hi.
Hi. Just a quick one, really. In terms of IT support, really, I suppose what we're having issues with is secondary care, primary care, and GPs having recording things and communications, and IT systems that don't communicate with one another, and different medical staff not being able to access certain parts of records. And I wondered if IPOS is common across Northern Ireland in a fortunate position where they can all access that.
The honest answer is we haven't gone electronically. We don't record the IPOS electronically and put it onto a patient care plan for GPs and others to actually see. Part of the rationale for that is that Northern Ireland is moving to a new single-based patient record, irrespective of whether you are in primary care, hospital, or whatever. And it's based on the EPIC work. I think some of the hospitals in England use EPIC, and it's going to be called Encompass. We wanted to put it on, but we were told because this new system would be in place within 2 years, they weren't going to invest in any new way of putting stuff on. However, what we have been trying to do, and I remember Fliss's words in terms of palliative unstable, palliative deteriorating. We're trying to include that language now in the discharge letters that we produce for our colleagues within primary care as a precursor to help us when the new Encompass system comes online. You are quite right. We still get lots of annoyed phone calls from our colleagues in primary care to say the correspondence out of acute is really poor. It's terrible. We haven't got this. We haven't got that. We've had a family have arrived with us this morning who were told yesterday that their mother, their father was palliative, but the GP hasn't received any information yet. And I think it is a work in progress.
Thanks.
Thank you very much. And we've got time for one quick question from Heather again, please.
Yes, it was just a comment for Ray about using the telephone IPOS. We had a talk by Brompton and Harefield, and they're working on telephone IPOS for the distant patients.
Oh, right, okay.
And they're using the patient filled. So for the patients who are well enough to fill out their own IPOS, then they use that over the phone to try and reduce safety gap. You know, obviously it's not going to work for the more poorly patients.
Yeah.
That was it. Just a comment.
Okay, thank you very much. Thank you very much, Heather, and thank you for everyone for your questions, and to Ray and colleagues for an excellent presentation. I think it's been very helpful to everybody. And I'm sure we could discuss much more, but just for the sake of time, I'm now going to hand over to Fliss, who's going to talk to us more about the definition of settings in specialist palliative care and timing of outcome measures within those settings. So over to you now, Fliss.
Okay, thank you.
Thank you very much.
And you're going to show the presentation, yes, okay.
Is that okay?
Yes, great, that's lovely.
We've got a slight time delay between the mouse and it changing elsewhere, so apologies for that.
No worries. So, a brief comment on some of the discussion that's gone before, particularly the display mechanism and the green, orange, red arrow thing. We've been doing work with a number of sites to try and refine how we might usefully present IPOS data, and it's quite helpful perhaps to maybe share that with the group next seminar, because it's refined quite a lot, and I think it may be a really interesting thing, Ray, to think about how that can be presented in a way which is really meaningful for people. I like the idea of colours and the way those colours are used, but there is also some constraints over what one can do with smaller amounts of data. So I would be happy to do something on that maybe next time.
Thanks, Liz. That would be really helpful. Thank you.
Okay. So I just wanted to go on to the issue presentation. And I was very cognizant of the fact that the topic for this call is about, or for this webinar, is about how we can use some of the measures across settings. So I think that's a real challenge. And I wanted to just talk you through some of the discussions that we've been having with the sites that we've been working with, which we've been doing very much back and forth to try and find out what's useful for them, get some feedback, refine how it might be done, and then try another way. And Alison, I know you're on the call, and you will bear witness, I guess, to the sort of labour of doing that. It takes quite a long time to go back and forth and work things out. But I thought I would distill the sort of wisdom of that process as much as I could and as far as it's got. And I'd be very happy to take any kind of input from any of you about additional wisdom that you've learned. So if one is going to use the measures across settings, the first challenge is that you actually have to define what the different settings are. And it may sound a little pedantic to say that, but you will see how complicated that actually is. Then there's an issue of the timing of the measures, because actually if you're using them between settings, you really do have to make sure that everyone is consistent in the timing so that they know what to expect as the actual measure, as it were, moves between settings. So I'm going to talk about that in relation to palliative phase, AKPS and IPOS. I'm not really going to talk about the other measures in any form, but we can have a conversation at another time if needed. So one of the challenges is that if you go to different hospices or community teams, and sometimes even to hospital advisory teams, you do find quite different models of care. So what is described in one place as their community service may be very different from what's described in another place. And so we've been trying really hard to be consistent about how we're going to define that. If you can imagine, particularly the community setting, there's lots of diverse ways that people deliver care. You described the community, I forget what it was 4 initials, I forget, Ray, but the community service that you were delivering, the community centre, I think you called it. But everybody has a different model and it's really hard to unpick. So I think in the issues present, the document, I've actually outlined a few of these things. So some people still have a daycare type of service. Some people have modified daycare into what might be called sort of new models of daycare. Some people would have a lot of the traditional community nurse-led visiting service, and others are using much less of that and beginning to develop, for example, models where you have a remote consultation, such as was described by Ray. And then there's all sorts of different clinics or AHP type inputs, etc. So one of the ways we've tried to help with this is try and be consistent about how those things are defined, so that if, Ray, for example, you were talking about a particular type of community service and you were reporting on your IPOS data from that, we would all know in our services whether our data might or might not be comparable. So if we move on to the next section, we've tried to define setting as one of 5 options. Next section, please. And basically, these are they, 5 options which are listed here, A to E. Hospital inpatient, hospital outpatient, hospice inpatient, community own or care home, and community outpatients. Now, just let me clarify this. The hospital one is fairly intuitive and easy to understand, and the hospice inpatient is usually easy to understand, although There are examples such as nurse-led beds or continuing care beds, which may influence the IPOS findings or the phase findings. So it's not quite straightforward, but generally one could group hospice inpatients together. The tricky part comes when you talk about community. And we think the best way to distinguish between the different models is to ask the question, does the patient come to us as professionals, or do we as professionals go to the patient? And that allows you to separate the community models at least into two distinct categories. And you can see that that is a very clear definition. Either the person is coming into a service, a daycare, an outpatient, etc., or they may be in their home, in their care home, in the relative's home, and the service is coming to them. That's the first categorization, and it's very intuitive, very straightforward. The difficulty is that still within both those divisions, there is a real mixture, okay? So first definition done. There's then another step which says, actually, we need to allow local services to define the teams that are delivering those local services. So within the group where services go to the patient, there might, for example, be a traditional CNS-led visiting service with or without doctor visits as well. And there might then also be something completely different, like a hospice at home. So hands-on care, often 2 or 3 visits a day or more, sometimes night visiting as well, or night support, and much more like a hospice towards the end of life. So that is helpful. And we've then gone on to try and work with services to try and define when would it be reasonable to expect measurement of the different measures in each of those different settings. And then if you go, I think we have said, moving on to the second question, yeah, that's it, just back a little bit. We've actually defined what is our recommendation for the timing of outcome measures in each of those 5 settings. Okay, so in the hospital inpatient, if you look at the number of contacts usually provided by a hospital advisory palliative care team, it's often only 2 or 3. There are some people obviously who have a lot longer, but the majority only have a small number of contacts, maybe a maximum of 5. And usually you'll find that either 2/3 or perhaps even 75% of the work is a smallish number of contacts. And for that reason, we think it's reasonable to say, measure phase AKPS and IPOS with each contact. And that gets round the problem that often in a hospital context, you don't know when somebody's going to be discharged. You may think you're planning ahead for it, and then suddenly they're whisked out of hospital. And it allows you to ensure you've got an IPOS or phase and AKPS close to discharge, so that when you do want to communicate that to a community team who may be receiving the patient, you've got something that's relatively recent. Hospital outpatient is fairly straightforward. Phase, AKPS and IPOS with each contact. Some hospital outpatient contacts, there'll only be 1. And that may mean there won't be a second one for follow-up, or you could sometimes give one to the patient to post back after an interval of time if that was appropriate. Hospice inpatient is probably also fairly straightforward, because phase could be measured daily, and then AKPS and IPOS can be measured at first assessment and at change of first phase, and then at end of episode. And that is simply 3 measurements, which makes it a little bit easier for people. The reason we're suggesting this is because in an inpatient setting, usually you get most of the impact of care within the first phase. And for those who actually deteriorate and die, you can see the impact over the whole episode. So therefore it makes it simpler and it makes it less burdensome for staff. Okay, we'll come to questions at the end. Moving on to the community setting, we think that if it's a visiting service where the professionals are going to the patient, that actually phase AKPS and IPOS probably should just be measured with each contact. That will be driven by clinical care, because actually if somebody is stable, they probably won't need visiting very often. And so therefore they won't need their measures very often. And it's almost as if the clinical changes are driving the frequency with which the measures are captured, as they drive the frequency of contacts. So that to us is very logical, and it seems to work for services. And then finally, before that, the hospice at home is a specific case. And I think when we've talked with hospices about this, or with community services about this, they would suggest that the hospice at home is simply a first and last measurement, so that there's one on first assessment and then there's one at the time of death or close to the time of death. Now, it may be hard to capture some of those, and we are working on guidance for what are the relevant IPOS items in the dying phase. That will come soon, I hope. And then going lastly to the community outpatient setting, we're suggesting again that phase AKPS and IPOS are measured with each contact, very similar to the hospital outpatients. So this is something that we've been talking to services about and trying to refine, trying to clarify, trying to make the definitions really clear. And we think it is beginning to evolve into something that we're going to be recommending nationally. It would be very helpful to have any thoughts, feedback, comments, either in this discussion or subsequently. Happy for you to email me or whatever's useful. Thank you.
Thank you very much, Fliss, and that was a really clear walkthrough. It's something that's very complex, I think, but actually you've managed to lay it out in a very straightforward way that I think people can hopefully will be able to relate to. So thank you very much for that. We've got a question from Victoria Bradley, who's apologised she's had to leave the Echo early today due to clinical commitments. Victoria's at Soval House in Oxford. She had hoped to ask if anyone else in the group is using an electronic record, so we could perhaps post that on the chat and Victoria can pick up on that when she looks at the recording, because I'm conscious that Fliss, that you are also wanting some feedback on this now. So that's about Cerner Millennium EPR as an electronic record, but we'll post that question on the chat and people can answer to that if that's all right. And she's happy for people to email her if necessary. So just wanted to bring that in. So feedback for Fliss on, does this feel like it would make sense? Does it something that you'd like to use? Who'd like to start?
Hello.
Hi.
Hello, it's Heather here.
Hi.
I just feeding back on the community-owned care home section for Fliss. The Rennie Grove Hospice at Home service is quite a different model. So we're built on a CNS, a band 6, band 5 nurses and healthcare assistants. So at the moment, what we're trying to do is assess at each change of phase. And as clinical audit lead, that's what I'm trying to unpick. So I just wanted to highlight that that was different for us and in the work that we're doing. And if you had any feedback on that.
Yes, that's really interesting. I would be really keen to work with you a bit more because of your different models. And I think I've sent a few emails and hope to kind of engage a bit more. But if you would like to kind of be part of the conversation that we're having, I'd be really keen to hear from you.
Yeah, yes, absolutely.
I wonder, could we ask a question?
That would be, yes, far away.
We were just commenting on the difference there between a hospital inpatient and a hospice inpatient, and certainly our experience in the hospital with our teams would be when those patients are less stable, they would be reviewed by the hospital team on a daily basis. So the suggestion of doing the IPOS along with the phase and Carnoustie every day, I think would probably be a challenge for our team, and we wonder why that should be different to it would be as a hospice inpatient.
Fliss, can you unmute yourself? Can we unmute Fliss?
We can't unmute Fliss because she's muted herself.
Fliss, you've muted yourself.
Sorry, I've got a slightly delayed connection.
That's fine. There's a few delays going on. Don't worry about it.
So most places that we've worked with, if you look at the profile of what's happening in an inpatient hospice and a hospital advisory team, they're very, very different. In a inpatient hospice bed, there will be many contacts with the patient in a day. The average length of stay is usually about 12 to 14 days. Whereas if you look at acute advisory hospital teams, I'm not talking about beds that are managed by specialist palliative care in hospitals, because that's essentially the same as a hospice. I'm talking about the advisory teams. Most of them have a profile which is very different. So they will often have daily contacts for the acutely unwell people, but they'll sometimes have, you know, a contact every 2 or 3 days if somebody's getting better. But if you look at the length of stay, it's often much shorter, and it's the contacts that the team have with people is often very small in number. And that's why we're making this suggestion. Now, obviously, if the practice is different in your hospital and you have a longer length of stay and you have much more frequent contacts that go on for 2 weeks on average, then you might need to reconsider the model and go with the change of phase. But most of the acute hospitals that we're working with actually have, you know, average, I think the median length of stay is usually 5 or 6 days. And the number of contacts is often 4 or 5. So that's why we're suggesting this.
I suppose our question is, you're right, the nature of the hospital now has changed in terms of as soon as you're in, they're trying to get you out. And I think that's the same for everyone. We could see somebody in the morning, start an intervention and review them in the afternoon. So that's 2 contacts in 1 day. And then review them the next day twice. Then there might be a space, and then we review them before they go out. So in the suggestion in your model is that nurse or doctor will do 2 IPOS assessments in 1 day for that patient. So that could be 5 in total in a 4 to 5 day period.
No, we wouldn't recommend doing any of the measures more frequently than once a day. So maybe we need to put that in as a rider, and we need to make that clear, because actually phase is not sensitive enough to pick up changes more often than once a day. So in that instance that you've described, that would be 3 measurements.
Yeah, so that's why I think we were struggling, as I said in the presentation, we looked at first assessment and discharge to try, because you're right, the phase, the space between the phases was too close then if we did it every time we saw a patient. Could we link in with you, Fliss, then maybe to explore that a little bit more?
Yeah, very much so. Drop me an email and then we can maybe have a discussion. I'd love to have a discussion about some of the earlier stuff you were presenting as well. It'd be really helpful.
That'd be great.
Thank you.
Thanks very much. Can we go over to Heart of Kent? I think, Georgina, you've got a question there, haven't you? Thank you.
You're unmuted, you can talk.
Yeah.
Hello, it's Kerry, Patient Services Director.
Oh, sorry.
That's fine. I just wanted to say that on our inpatient unit, we are using, we're reviewing AKPS and phase of illness every day, so on a daily basis. We do IPOS on admission and on discharge, But what we're also doing is IPOS on so our main ward round, our main consultant ward round is on a Monday morning. So we do IPOS on a Sunday afternoon, evening with the patients that are on the unit to inform the ward round the next morning. Which then our MDT is on a Tuesday, so we've then got those scores that are fairly relevant still to inform the MDT. We use patient care volunteers to sit with patients wherever possible to complete the IPOS. So we've trained our patient care volunteers to use the IPOS. So that's what we're doing. In our community team, we've got a skill mix, and we're very much doing IPOS, so AKPS, again, phase of illness on virtually every contact. We're updating that on our electronic healthcare record. IPOS we're doing on first assessment, on phase of illness change, and we don't generally discharge patients, so it's generally around if they've had a hospital admission or some sort of change in their situation, we would then instigate doing another IPOS. So that's the way we're working at the moment. The other thing I just wanted to say is, although we've done a lot of education with our teams, we are repeatedly having to revisit what the phase of illness definitions are fairly frequently, because you get hooked into deteriorating means that, you know, that downward slope of a patient rather than looking at the plan of care. So there's a couple of us that are MDTs that are quite picky, and we really unpick, is that the true phase of illness?
I do know one team that's running the 3-minute video before their MDT in order to get everybody onto the same page.
Yeah, we think that is so valuable. We've just circulated it again. But you very quickly, however well you think you've educated your teams,
they
you
slip
into that deteriorating, you know. And also getting people's head around, the same as the gentleman in Northern Ireland said, the bit about stable and unstable, and, you know, might be medically fit, but not necessarily stable. So
yeah, you've got to say palliative unstable.
Yeah.
Just to come back to your earlier point, I thought it was a really good one. I think there's no problem with individual sites using measures to serve their purposes. For example, you're doing the day before the MDT.
Yeah.
But bear in mind that we'll really get the value from doing all this when we can start to compare between different sites. And if you're going to compare your IPOS changes or your phase changes with another site, we just need to make sure that we're comparing apples and apples and not apples and bananas. So if we were looking at IPOS change in your service to say what's the change from the first assessment to the Monday before the MDT, that would not be the same as St Christopher's, for example, over the first phase, for example. So it's just about trying to really understand that we're all doing the same things in order to then really later down the line reap the benefit when you want to know how your service is doing in relation to the national standard.
That's really helpful, because we really are very keen to look at benchmarking and how we're doing against other, you know, with other organisations.
And we've been doing a lot of work on that. And in fact, we've, Alison, I don't know, do you want to say anything about how we've refined, certainly for the inpatient unit at St Christopher's?
Oh, sorry, am I muted? Yeah. Yeah, so at the inpatient unit, we were doing, well, we were pretty much monitoring phase and AKPS every day. And the phase of illness, when it changed, we were doing an IPOS. But then we changed to do it more frequently because we weren't necessarily getting the results that we wanted. But in fact, that just complicated matters further. So we have now gone back to just doing the full IPOS when the phase of illness changes, and on admission and on discharge or death. That's the plan anyway.
And what's been really interesting, looking at the recent data, which is, I think, really good quality, it shows that there is some impact on physical symptoms in the inpatient unit within the first couple of days, but the majority of the impact is seeing the psychological and communication changes over the whole episode. And it's really exciting to see that, because even in this group of patients where 2/3 of them are going to die, or something like that, it's about 60% die, I think. A really sick group of patients, there's a real shift in the psychological well-being for these people, and a shift in their kind of communication support. And that's really exciting because it's done in the context of really advanced illness. And I think, hopefully you saw that recently, Alison, and it was quite...
Yeah, no, the spider trap.
Very inspired.
Yeah, it's very exciting.
That's great. Thank you very much. I'm very conscious of time. What we can do and what we will do is leave the chat room open for a few minutes after the session has ended. So if anybody's has got some further thoughts they want to share with Fliss or any other comments they'd like to make, please do use the chat function. We'd also like you to just put into the chat, if you can, what did you put into practice following our last session on phase of illness? And we've had quite a lot of discussion about that today as well. So it'd be really helpful if you can say one thing that you put into practice following the phase of illness last session. And please, if you could also mark out of 10, with 10 being the most beneficial, how you found this session today, that would be great. What I'd like to do now is just really thank Ray, Tracy and Denise for an excellent presentation. And I think looking at the systems approach is so fascinating. I think you found some real barriers that will be familiar to all of us. And I think raising the kind of question around electronic systems and whether they speak to each other has got a lot of knowing nods from everybody. So thank you very much for that. And thank you, Fliss, for sharing with us that about the location and work that you've been doing and looking at that most recently. I think that stimulated some really interesting discussion. So the chat room will be open for a little bit more. The reminder, the next session is on the 28th of November at 3:30, and we'll look to pick up Fliss's suggestion around actually that kind of reporting of presentation of IPOS data as well. And use it, and we'll also be looking at using tools, less responsive patients, including proxy measures as well. Thank you very much, Hazel, for my prompt on that one. So thank you very much. Chat room remains open. Thank you again to the speakers, and I hope you've enjoyed this afternoon's session. Thank you very much.